Hi, everyone. My name is Zara Aziz, and I'm a lecturer at the School of Psychological Sciences, Monash University. In this presentation, I'll be discussing implementation science in low and middle income countries with a particular focus on a case study in India. Diabetes is considered as the health tsunami of the 21st century. And according to WHO, about 422 million people worldwide have diabetes, and the majority of them are living in low and middle income countries. There are about 1.6 million deaths that are directly attributed to diabetes each year. And both the number of cases and the prevalence of diabetes have been steadily increasing over the past few decades. Now let's look at closely what NCDs looks like in India. So non-communicable disease are the leading cause of death in all regions in India. And it is estimated that 53% of deaths and 44% of disability adjusted life years lost is due to non-communicable disease. The state of Kerala has the highest prevalence of non-communicable disease and risk factors. Now, the important question is, can diabetes be prevented? Several large randomized controlled trials have demonstrated that lifestyle interventions can be successful in reducing the incidence of type 2 diabetes from 29 to 67% in high-risk populations with generally good maintenance for up to 20 years, which is excellent. And since then, there has been a lot of attempt to translate these findings into various contexts. However, the incidence of diabetes has continued to rise only. And you wonder, why is that so? That's where we talk about evidence implementation gap. And it is evident from other programs that a wide range of policies and strategies exist at global, regional, and national levels, but there is only little impact on major health outcomes. And this implies a notable translation, that is evidence into implementation gap. And to this end, you ask questions like, what are the barriers to the translation of research? How to develop evidence-informed implementation in order to improve patient outcomes? Or how to effectively implement primary prevention of non-communicable disease in different contexts? And these gaps in the evidence to action cycle could be expressed as evidence to policy gap, policy to action gap, and evidence to action gap. To this end, Professor Brian Oldenburg and other collaborators around the world have been involved in real-world trials focusing on implementation and evaluation of lifestyle and community-based interventions, particularly in low and middle-income countries, under the banner of Non-Communicable Disease Unit, a program that is based in the University of Melbourne. And these trials are focused on testing new approaches to improve the uptake of evidence-based prevention in low and middle-income countries and building the public health research capacity of low and middle-income countries. And this is a snapshot of global translation and exchange so far, where Professor Brian Oldenburg and his team has been involved with. In all these implementation trials, the focus has been to apply what we know and transfer that across cultures, settings, and populations, recognizing that one-size approach does not fit all. And you will hear more about this cultural adaptation from Professor Pilviki Epsets in one of her future lectures. So you continue to initiate the global translation of evidence from one context to other contexts. And along the way, you realize that there are more learning experiences than entirely successful trials, and which is completely fine, as every implementation and or translation attempt is complex, but will bring invaluable learning experiences. One such implementation trial is Kerala Diabetes Prevention Program. That was a group-based peer support lifestyle intervention aimed at reducing the risk of type 2 diabetes in high-risk individuals. And this is going to be focus of my talk today. This is the Kerala intervention, KDPP intervention team, who were heavily involved in implementing this program in the state of Kerala. So the study was a cluster randomized controlled trial and was implemented in 60 polling areas of a sub-district in Trivandrum district of Kerala state, India. The primary outcome was the incidence of type 2 diabetes at 24 months. Secondary outcomes included changes in clinical, biochemical, and behavioral risk factors known to increase diabetes risk. And then we added an implementation question to this trial that was focused on identifying the participant, provider, and community level factors likely to influence the implementation of KDPP in India and other resource constraint settings. This is an excellent video of the KDPP, which you can easily find on YouTube. Please make some time to go through this video when you get a chance, as this video will give you a really good context of this trial. And I'm pretty sure this has been added as a key under the key resource section on the eHub as well. So you can find the link from there. Now, there are a number of publications associated with the KDPP program as well. So if you're interested in the program, you can read a lot more about the program and learn more about the program. And we have published a needs assessment paper, then we had the intervention protocol paper published. We then had a cultural adaptation paper, baseline characteristics of participants, effectiveness of clinical outcomes paper, and most importantly, we had a paper on implementation evaluation. And then in addition to that paper, we also published reach and recruitment of the trial as a separate paper as well, because there was a lot of interesting findings to report. So there's quite a lot of published material around this case study. So this is just a snapshot of our needs assessment paper. So once we conducted the needs assessment exercise, we had a bit more idea of what the intervention would look like and what will be different components of intervention. So this is what we came up with, which was the initial draft, as in these were the things we wanted to deliver. These were the outcomes we wanted to gain. The intervention components revolved around peer leaders and participants. So peer leaders were selected, were exactly selected from the same process through screening process as participants were selected. And the common denominator factor between these two groups were that they both were identified at the high risk of type 2 diabetes. The only difference was that during the first session, participants were asked to nominate 2 peer leaders from their group who they saw as leaders and reputable people, and there was a list of criteria, and then those people were either nominated or volunteered themselves to become a peer leader, and the group was pretty happy with the nominations. And then those peer leaders were received 2.5 days of training and receive a lot of support from the KDPP intervention team and from a local resource person, and receive other resources including peer leaders workbook. So these all resources help them to continue to lead those monthly sessions for participants. So peer leaders organized another 11-12 sessions for over the duration of 1 year, and they had a set sort of curriculum to discuss with participants in each session. And these were our KDPP outcomes, what we wanted to achieve at the end of 12 months. So this is a KDPP study design. Now I'm sure you can't, this is not visible to you. So these are all published in several papers. There were basically 60 polling areas, 15 from each legislative assembly. And they were randomly selected, and 30 polling areas were randomly allocated to the intervention and control arms in a 1:1 ratio. There were a total of 5,500 plus individuals between the ages of 30 and 60 years who were randomly selected and approached through home visits. Initially, we aimed to select 80 individuals in each polling area. However, this number in reality varied from 42 to 200 and something individuals, depending on the availability of records in the electoral roll, or incorrect addresses, or immigration, or deaths, or unavailability of participants at the house at the time of contact. So this was the initial screening period only. And from our pilot study in this area, we found that participation by men was lower than women selected for the pilot program. So we screened more men than women to achieve a gender balance in the actual study. So these were the contexts prior to the actual intervention rolling out. And again, the paper on reach and recruitment describe the whole story behind the screening and numbers and selection and recruitment of participants and their eligibility in a lot more detail. So the key intervention targets were around diet, physical activity, alcohol, and tobacco use. So reduction of sugar containing food items and beverages, increase in fruit and vegetables, and reduction of fatty food items and of rice portion size, increasing physical activities, reducing sitting time, and increasing amount of incidental exercise. No consumption of alcohol and no use of tobacco. So these were the key messages through several activities and intervention components. So going back to intervention components that I showed you in the diagram previously, there were four key sort of components where every activity or every intention to deliver education-based program fits in. So the four components included a group-based peer support program consisting of 15 sessions for high-risk individuals. So these 15 sessions included sessions from peer leaders, session from intervention team, and diabetes expert panel sessions. And then we had peer leader training and ongoing support for intervention delivery component. So again, this is very important provider level factor that we need to consider. So these peer leaders had to be trained and had to be provided a lot of support so that they can continue to lead peer group sessions for a number of participants, for quite a lot of participants. So it was identified as a very important component. And you will see later in the presentation that this peer leader training component fits in under provider level factors. We then had a component around diabetes education resource materials, as there was a lot of material that was shared with the participants. And then the last one was strategies to stimulate broader community engagement. So we realized right from the beginning, straight after the needs assessment, that if we have to deliver a program that we want and we want it to make a successful program, we will have to come up with strategies beyond just targeting those high-risk participants. We will have to go beyond the participants. We will have to go to their families, their neighborhood, their community, and we have to have some broader community engagement with the program as well, which I'll talk about it in the next few slides. So these are the pictures from mobile clinics and pathology stations. This is a quick view of timeline. You can see that there was session 1, and then diabetes education session, and session 2, and then peer leader training, and then again session 3, and so on. So this is the paper of that shows the clinical outcomes and effectiveness of the trial. So this was published in 2018. So feel free to have a look if you are interested in the clinical outcomes. I'll discuss this in the implementation evaluation later on. So from this point, I will be discussing more about the implementation evaluation. So we thought that we definitely wanted to conduct an implementation evaluation of this trial, and we were looking at different frameworks. So exactly what you heard in the theories, model, and framework session. There are heaps of frameworks out there. You have to pick and choose which one would be suitable for your type of study. So we looked at both pipe impact metric, which might be a new sort of framework for some of you. It hasn't been widely used, but we have used it now at least 3 times for 3 different purposes. This is a simple, very much more simple framework than REAM, at least that's in my opinion. But we looked at both REAM and pipe, and we thought, okay, maybe we will combine some components of REAM, some components of pipe, and then we will see what's missing in. So again, going back to the point that how do I know that which framework is best for me? There's no simple answer to that. So you can see that for this implementation evaluation, we have combined few frameworks. So from pipe framework, we were less concerned about the program design phase. So size, scope, scalability, and sustainability. We were less focused on that. Although scalability and sustainability came quite a lot in our conversation and project meetings. However, for this particular implementation evaluation, we were more interested in penetration, implementation, participation, and effectiveness of the trial. And then with Glasgow's REAM framework, we were looking at reach, effectiveness, adoption, implementation, and maintenance. So you can see some overlapping in these 2 frameworks. So where these 2 frameworks led us to, we came up with these things. So if you can see that KDPP intervention inputs are pretty much same what I showed you on one of the previous slides, where we wanted to, we had peer leader component and group members component, and then we had things that we did to support peer leaders, including peer leaders training, handbook, ongoing support, and then things that we did to support group members, including group sessions led by trained peer leaders, group sessions led by KDPP team, diabetes prevention education session, and an introductory session. And then participants have had access to participant handbook, workbook, and education booklet. So just to remind you that the purpose of the trial was the purpose of the implementation evaluation was to evaluate the implementation aspect of KDPP, to uncover provider level, participant level, and community level factors that may influence the successful implementation of this trial in India and assess its transferability to other contexts. So what we did, looking at going back to REAM and pipe framework, we thought penetration into target population was very much on the implementer or provider level factor. So providers, implementation team, peer leaders, program teams, on the ground teams, those were considered as providers. And it was their responsibility to reach out, to penetrate into target population, to select the right people for this intervention. We then thought that implementation lied on the provider as well, adoption as in number of settings that were willing to initiate the program. And then we wanted to understand what were the facilitators and barriers to intervention delivery. We then look at participant levels, so reach, number of eligible individuals who enrolled in KDPP. We then looked at their attendance and retention of participants. We labeled it as participation. And then effectiveness was pretty straightforward. So we wanted to see % of participants who achieve primary or secondary outcomes. With participant level adoption, we wanted to see percentage of participants who participated in goal setting and utilized resource materials. So we monitored, so remember on the slide where I said that there were 4 components to the intervention key messaging, so diet, physical activity, tobacco use, and alcohol consumption. So we asked participants in those 12 group sessions to make goals around what they wanted to focus on, and then work towards that goal. So goal setting, people who were involved in goal setting and monitored goal setting were included in adoption. We then have participant satisfaction from the program, and then we had, again, facilitators and barriers to participate in the program. We also looked at the control participants evaluation. Another important thing was community level factors. So again, remembering that the two frameworks, REAM and PIPE, that I showed you on the previous slide, we had reach, effectiveness, adoption, and then we have participation, and then REAM had maintenance component as well, whereas you don't see maintenance component here because the way maintenance is calculated, this under REAM is overlapping with the definition of effectiveness. So we didn't want to use that maintenance definition, and we didn't have any data to measure long-term maintenance, whether people would continue to maintain the behaviors they have learned as part of this program. So we comfortably removed that component from this framework. And again, going back to our discussion around theories and frameworks and models, it is fine to only adapt the bits from the frameworks that suits your evaluation, as far as you have a good reasoning to support that. And again, some components here are from PIPE, so penetration, implementation, and then participation and effectiveness. And then we thought that facilitators and barriers was an important thing to look at, so we included that, but we also thought that community level factors were really important to explore. So we looked at percentage of participants who took part in community activities outside their group sessions, and these were the community activities that we didn't necessarily plan for them. So some of them were really engaged with the program, and they created a lot of community activities opportunities outside those group sessions. We also looked at proportion of participants who had contacts with peer leaders and group members outside the group session, and participants who received support from other community sources. And we also wanted to understand facilitators and barriers of community level facilitators and barriers. So there were a number of data collection tools that we created as part of this implementation evaluation to collect data on peer leader training, effectiveness of peer leader training. So we did pre and post test analysis. We did peer leader training evaluation. We also asked peer leaders to complete a group session report for us after every session. We had observation tool checklist. So what was this observation tool was that we came up with a group with a set of things that we wanted to see in these sessions. So because peer leaders were running these sessions, we wanted them to run those sessions with implementation with certain set of fidelity. So we provided them that training that make sure you greet participants at the beginning, make sure you discuss the reflection from the previous session, you ask them what they've done between the session, you ask them how they are going with their goals and stuff. So we came up, while we gave them all the tools to follow the prescription, but we also were fortunate to have a local resource person who was in each area, in each polling booth, who was sometimes able to attend that session. So whenever they attended that session, they completed an observation tool for us, which was essentially a checklist, in which it was, there were questions like, did peer leader welcome or greeted participants? Did peer leader invite participant to ask question? Did peer leader did this? Or are participants engaged with the session? Are they asking questions? So it was more of an observation than anything else, and those were used for formative assessment as well. So the intervention team was closely looking at those observation checklists as they were coming in, and if there was a need to speak to peer leaders or support them with more resources or support them with facilitation skills, the intervention team was doing that as well. And we thought that the nature of session 1 could have been very different to other sessions for obvious reasons. So we designed 2 different checklists. The first one was used for initial session only, and then other one was used for the remaining 11 sessions. We also asked participants to complete a 12-month evaluation for intervention, evaluation for the whole intervention for us, and we also ask the same evaluation from control participants. So there was quite a lot of data that was collected as part of this implementation evaluation. So these are the tools, data collection tools with time points, and who was responsible to collect this sort of data. Yeah. So again, implementation evaluation was mainly focused around provider level factors, participant level factors, and community level factors. Now, looking at the provider, now there are, I have a lot of slides after this point discussing about different measures, provider level, participant level, and community level. I won't go into detail on every single slides, but you will have access to these slides. You can have a look if you're interested. Basically, we just tried to then measure what we promised in our logic framework, that we will measure the penetration. So we looked at the total number of individuals that were identified from the electoral roll of selected polling areas. And then we were only able to contact 67% of individuals during home visits. So we committed, like we got the individual records for 5,517 with the intention of reaching out to these people. However, in reality, we only were able to reach to 67%, and the reasons were beyond our control, including incorrect addresses, people have moved out, they have passed away but haven't been removed from the electoral roll. So there could be multiple reasons for that, but I think this is a good indicator when you're talking about implementation and translation, because you are looking at penetration in your target population. So you wanted to reach 100% of people, in reality, you were only able to reach 67%. So future studies can learn from this experience and then target the numbers, because they now know that there is about 33% of fall down from the penetration perspective. Then we also realized that there were more women who were contactable than men, again, for reasons like men were out at work most of the time. And then the remaining individuals, as I said, could not be contacted because of number of reasons. Now, participant level major participation. So of the 3,400 individuals who were assessed for eligibility, 29% were enrolled in the intervention or control arms. So, and in terms of attendance, on an average, the participants attended 8 sessions, median 9, mode 14. Out of 15 sessions, 49% of the participants attended 10 or more sessions, and 11% attended all 15 sessions. And 12-month retention rate of participants was 97% in intervention and 98% in control. So those were huge retention rates. Implementation. So you'll see I'm switching between provider and participant level, and the reason is that I'm looking at PIPE framework first. So I've looked at penetration, P for penetration, P for participation, I for implementation, and then there will be effectiveness as well. So we are going by frameworks. Of the 60 peer leaders who were originally identified for training, 51 attended a 2-day peer leader training. So we factored that as a provider level factor, which was related to implementation. So we monitored that if all the people who were identified as a peer leaders in first go didn't necessarily attend the training, which means they never became a peer leader of any groups. Then we looked at the pre and post training knowledge score of peer leaders, and that was shown to be increased from 27 to 33 with a mean difference of 5, and that difference was significant. So that gave us a bit of confidence in our peer leader training. We also noticed that 97% of peer leaders stated that the training had prepared them for leading the groups, which is great. And there was a lot of ongoing support provided to to peer leaders, including telephone contact before and after each group session, face-to-face meetings, and assistance in organizing group sessions. We couldn't necessarily monitor the numbers of all the telephone contacts because some of the contacts were made randomly. And again, face-to-face meetings could have been as and when needed or at set frequency. So we didn't necessarily record all the data around that. Continuing with the implementation, we had 29 out of 30 intervention groups organized, all 15 group per session over the 12 months. So there was one intervention group who was formed, but then due to certain reasons that group was resolved, and interested participants joined other groups there. So we had 29 out of 30 intervention groups there. Peer leaders completed group session reports for 54% of the sessions. So again, this is an important element to consider, that we created those session reports with the intention that those will be used for formative as well as summative assessment. The fact was that only about half of the peer leaders completed, half of peer leaders completed half of the reports for group sessions. On average, this session lasted for 1.25 hours. So we asked them that at what time session started, what time session finished. And peer leaders said that they spent between half hour to 4.5 hours in preparing for each group session. So again, with the mean hours of 1.7. So some people took a lot of time in preparing themselves before the training, and these were all volunteered peer leaders. In terms of group sessions, 77% and 23% gathered a lot of and some information respectively from peer leader handbook. We particularly asked them that which page numbers they extracted the most information. That gave us a bit more insight into what sort of information peer leaders need for this sort of intervention. And the topics covered during the group session, we asked them what topics did you cover, and these were the topics that were discussed in the group sessions. Again, participants' motivation. So we asked that 73% peer leaders rated participants' motivation as very motivated. Peer leaders thought that sessions were useful in achieving the KDPP program targets. A majority of participants felt that the monthly group sessions were very useful for them, and 98% reported that they had shared the learnings gained through group sessions with their family members, which was again excellent indicator of the impact of the program and the wide range of program impact. Again, this is all the data around observers checklist. So observer checklist was completed for 28 out of 29 groups. So this was in reference to session 1. So 28 out of 29 groups, local resource person completed these checklists for us for session 1. And these were the numbers, like 85% of peer leaders completed registration, 93% used introduction and ice-breaking strategies. So there was a lot of information around what actually happened in those, and those sort of measures helped us measuring the implementation fidelity of the intervention as well. This is the data from Observers Checklist 2, a slightly different kind of questions, but on the same theme, that what happened in the actual group sessions. This was again a really important sort of indicator for us. So we focused on facilitation style as per protocol. So this is again measuring implementation fidelity. So you can only teach peer leaders that how you want them to deliver the intervention. However, there will always be an autonomy supportive behaviors pertaining to individuals as individuals who are actually leading or facilitating that. So 78, so we asked some questions around that, and 78% stated that they were always free to choose the kind of lifestyle changes they wanted to make, which was, so this is coming from individuals. So individuals are asked that, during your goal making process, how much you were influenced by peer leaders. So this was a good sort of indicator that 78% thought that we were always free to choose the kind of lifestyle changes I wanted to make. And they understand, they thought that their opinions were understood and appreciated in the group. And most of them felt that their peer leaders encouraged them to ask questions in group sessions. So there could be different flavors of facilitation among different people and different peer leaders. But from this data, it seems like that peer leaders actually followed what they were supposed to follow. So that was an excellent finding. And that explains some of the results of the effectiveness of intervention as well, that the implementation fidelity was quite high. Effectiveness, so this is straight from the effectiveness paper, that at 24 months, the overall incidence of type 2 diabetes was 14.9% in the intervention arm as compared to 17.1% in the control arm, which wasn't a huge difference. But then we also noticed that 83% of participants in the intervention arm were more likely to consume more than 5 serving of fruit and vegetable, 20% were less likely to use tobacco, and 23% were less likely to consume alcohol compared with the control participants. So although clinically the difference wasn't huge, but there were some excellent behaviors that were adopted as part of, as a direct result of this intervention. Adoption around, indicator around adoption, and then we ask about the facilitators to participate. So the people who were enrolled in the program, majority stated that the location and timing of the group session were very convenient or convenient, and that they were very interested in learning more from group sessions. Whereas as the barriers, there were 48 participants, or 10% of total enrolled, who were enrolled in the intervention but did not attend any sessions. And 44% of them stated that the time and location of the group sessions were not convenient for them. So although location was seen as and timing was seen as the biggest convenience for people who attended the session, it was clear that people who did not attend the session, 10% of total enrolled, had issues with location and timing. So again, important learning for future trials. And 15% stated that they were not interested in attending group sessions, whereas 40% stated that these sessions were not useful for them. So maybe this could be embedded with the participant retention strategies, that people who are eligible and who have consented to participate understand that why they've been selected, why they've been identified as high risk, and how this program can help them as well. Community-based activities, so we look at the intervention, extra interventions that were outside the group and that were organized by community. So people started doing their walking groups, they came up with kitchen garden training, they did yoga sessions, and then 75% participants had contacts with their peer leaders outside the group session as well. And on an average, 11 contacts were recorded between peer leaders and participants over the duration of 12 months. So so people were meeting their peer leaders outside. Again, the nature of these contacts were varied. Some people said that they continued to discuss about their goals, and it was mainly around the in context with the intervention. Again, community level facilitators and barriers. We found that commitment of the local political leaders emerged as one of the major facilitators for high uptake of the program. So local political leaders and panchayat leaders and community leaders were identified as the key stakeholder of this program, which really paved the way. That community was very open to accept the program as it was endorsed by their local political and community leaders. People found that, yes, you are telling us to do physical exercise activities, and it is great, but we don't have any suitable public places for conducting physical activities. And then lack of support by the local community in one intervention community was seen as a facilitator. So there was only one group who thought that our local community didn't support our initiatives. and the rest of the intervention arms, intervention groups had really excellent experience with the community groups. So all in all, key success factors. So we concluded that home visits that guaranteed reasonably high reach made by trustworthy community-based organization was seen as a key success factor. So going back to our program participation and reach, so we were able to reach out to many people, and that was due to home visits. But particularly, we also thought that peer leader training program that was feasible to deliver, easy enough to receive, and relatively short, but managed to provide skills needed as perceived by peer leaders and participants. So both peer leaders and participants had a really good feedback around peer leader training and facilitation and usefulness of group session. Education resource materials were perceived useful and actively used by peer leaders and participants. And so support provided by family and friends was seen as as again a very a success factor in this intervention. So many people reported that the things that they have learned at the group session, they've been able to share this with their family and friends, and family especially, as if they were making changes to their diet and portion size and physical activity as a family, so involving everyone, which was a great outcome. KDPP intervention team's ongoing support to peer leaders was seen as an instrumental for the success of this program. Local resource person with a broad role to support peer leaders in practical arrangements, as well as linking with community, was seen as a key success factor. And engagement of community organization and members to practical activities was also seen as a success factor. What needed to be further improved? So timing and venue, as some people identified them as barriers. Timing and location of group session, possibility to replace or complement face-to-face meeting with other delivery modes came up as one of the possibilities. And a lot of research, delivery mode, one of the delivery mode that comes to mind could be online, but then a lot of other delivery modes, for example, there has been a lot of trials around lifestyle interventions at workplace. So that could be one possibility there. We also thought that inclusion of additional group activities, such as arranging regular physical activity classes for group participants, could have been further engaged and motivated participants to make those lifestyle changes, and inclusion of additional sessions from diabetes experts. So some people thought that they needed more than 2 sessions from diabetes experts. So we thought that could be something which future implementation trials can address. So next few slides are from Professor Bryan's presentation. So I won't speak to them, but there is a lot of work going on at the moment, and have been done in the past to scale up KDPP intervention model to more districts and more settings within India, and with the top-down and bottom-up approach from power to empowerment in KDPP. And then there was a World Diabetes Foundation grant that made some scale-up activities made possible around this intervention. And this is mainly the team who was trying to deliver the intervention, and then team in India at Sri Chitra Institute, who was instrumental in making this program a success. So we concluded that the successful implementation of this trial will contribute to improve policy and practice regarding lifestyle intervention programs to prevent diabetes in India and other resource constrained settings in the future. So I think the beauty that implementation evaluation brings to this trial is that the level of details that we have provided in the implementation as part of implementation evaluation, if someone had to take this program and had to replicate them in other settings, whether in India or outside India, there is a lot of information available as part of implementation evaluation that they can use and bank on in order to design their version of implementation of their program. And this is where the translation, trial, and evidence evidence and program practice gaps comes in. So you can have this have these implementation evaluation findings available for other trials to learn lessons from and to understand your own trial better as well. So these implementation the data from implementation evaluation helped us understand the broader issues with the trial or broader success factors with the trial as well. On this point, I will also indicate as a systematic review that we did as part of this program was we looked at the implementation trials from the last 15 years, particularly in type 2 diabetes, and we conducted a systematic review to see that what sort of implementation what are the key factors or key components of implementation that has been covered and that we should consider that other people have covered, other trials have covered, and we should consider for our program. And there were 38 trials that were included in our systematic review. And up to our surprise, we found that there were only 3 or 4 trials that actually reported all the components of implementation evaluation. So we use PIPE framework, so penetration, implementation, participation, and effectiveness in looking at those 38 trials, and we couldn't calculate any PIPE overall public health impact or using that matrix because none of the trials included enough information on these 4 components: penetration into target population, participation, implementation, and effectiveness. So there was so much data missing from that studies. So that systematic review is published in the Implementation Science Journal in 2015, and that was marked as one of the top 10 most influential articles in implementation science in 2015. So you will find the resource under key resources on eHub. So feel free to have a look at that paper if you want to understand a bit more in reference to implementation trials. And in the end, I just want to acknowledge our research collaborators, colleagues, and staff and research students who have all been part of this journey. And this lecture has been almost close to 50 minutes, so apologies for a long lecture, but I hope you enjoy, and I look forward to receiving any questions or comments. Thank you.